I would like to say welcome and thank you very much to our Kokua member and colleague, Dr. Ilan Bernstein. I'm going to do a brief introduction and then we're going to turn it over to him. So I have been very interested in this topic for a long time, and I'm really glad that Ilan has agreed to talk with us today. Dr. Bernstein joined the Pain and Palliative Care Department at Queen's Medical Center as a staff physician in 2013. He graduated from the Keck School of Medicine at USC in 2008, and he is currently board certified in internal medicine and hospice and palliative medicine. In addition to his clinical responsibilities at the Queen's Medical Center, Dr. Bernstein is an assistant clinical professor in departments of internal medicine and geriatrics at the John A. Burns School of Medicine at the University of Hawaii at Manoa. He is a member of the American College of Physicians and the American Academy of Hospice and Palliative Medicine. So Ilan, welcome and thank you very much. Oh, good. Hope has figured out how to give you a lay virtually. There you go. Again,
well,
thank you very much, Ilan, for coming.
Thank you, and thank you for having me. It's an honor. So again, I'm Ilan Bernstein. I'm with Queen's Medical Center. It's good to be with you all today. We're going to be talking about psychedelic medicine and palliative care, titled An Exploration of Old and Ancient Therapies to Address 21st Century Clinical Challenges. We're going to define psychedelics today. We're going to review biochemistry. We're going to touch upon some history, discuss mechanisms of action, describe the 21st century psychedelic renaissance, and consider future directions. So some disclosures for today. I have no financial disclosures to report. None of the content in this talk is to be construed as an endorsement to engage in anything that's illegal under federal or state law. And we're going to be discussing treatments that are under clinical investigation and are not FDA approved. So none of the content of the talk is to be considered a medical recommendation, and no doctor-patient relationship is formed through participation in this activity. So we'll start with some definitions. The term psychedelic is a term that's been around for just under 70 years. It's derived from the Greek, translating to mind manifesting, although I understand it's not a perfect translation. And it was coined by the psychiatrist Humphrey Osmond in a correspondence with Aldous Huxley in 1956. When we think about psychedelics, we tend to break them down into what's considered classic psychedelics, what we tend to think about. Those are the tryptamines, LSD, psilocybin, DMT, or 5-MeO-DMT, and then the phenethylamines, and the classic phenethylamine is mescaline, or DOI, dimethoxyiodoamphetamine. There's also novel psychedelics, and there's some controversy with those. Some people will consider some of these in the psychedelic class. Others will say it's a different kind of medicine or substance. But the novel psychedelics might include MDMA, which is a phenethylamine, ketamine, which is used in anesthesia, salvia divinorum, which is a kappa opioid receptor agonist. Some people consider cannabis a psychedelic as well, and under certain usage and circumstance. So this is by no means an exhaustive list, but just to give you some sense of how people classify psychedelics and then break them down into different categories based on their chemical structures. So when we think about the tryptamines, many of us blamed our post-turkey Thanksgiving meal fatigue on this amino acid here, tryptophan, although it was probably more overeating than anything else. But psilocybin, which is the active ingredient found in magic mushrooms, in the psilocybe mushrooms, psilocybin is derived ultimately from the amino acid tryptophan. And we can see here that its chemical structure is quite similar. Most people are familiar with the pathway that creates dopamine from the amino acid phenylalanine, and these are the phenylethylamines. But as we go down this pathway off dopamine, we can see this side branch, and this is how a cactus forms mescaline. which is what's in peyote. So psychedelics have been around for a long time. They've been used in ancient healing practices for thousands of years, including in ancient Greece, where a substance named kykeon was used, and it was a drink made with water and barley. Contamination with ergot was thought to have yielded LSD-like properties. In South America, DMT containing brew derived from a shrub containing DMT, and another plant containing an MAOI was combined and is combined to create ayahuasca. In North America, indigenous peoples use psilocybin containing mushrooms in healing and spiritual practice, as well as mescaline containing cacti. And in Africa, ibogaine, derived from the root bark of the Tabernanthe iboga, was used. In the West, the research really came to light in the mid-20th century. In 1938, Albert Hofmann synthesized LSD, rather by accident. And then we see here on this graph that the research kind of really kicked up in the 1950s and 1960s, ultimately until 1970, when the US passed the Controlled Substances Act. That effectively made it very difficult to study psychedelics. And we see this drop off in research happening. And then around 2000, the research starts coming back online. This time more psilocybin than LSD in the 21st century. And that may have been in an effort to avoid the cultural baggage that LSD took on in the 1960s. So when you think about mechanisms of therapeutic action, there's biomedical effects, there's direct anxiolytic and antidepressant effects. They tend to promote neuroplasticity, and that seems to be what causes the anxiolytic and antidepressant effect. And that can last for weeks and may account for the so-called psychedelic afterglow. Psychedelics have been used as a catalyst at lower doses for psychotherapy. This is the so-called psycholytic model. It was tended to be used in Europe, again, at lower doses where people were able to interact with the therapist, and it was kind of used as a lubricant to bring down psychological defenses so that people could engage in psychotherapy and psychoanalysis. And there's an experiential component which may hold significant meaning for people. At doses ranging from lower to higher, people may have aesthetic experiences or biographical experiences, and ultimately mystical experiences or transpersonal states at the higher doses. So when we're thinking about the biomedical response to psychedelics, we can kind of break that down into what's happening at the subcellular level, at the neuronal level, at the regional brain level, and then at the global or cognitive level. The primary mechanism of action is agonism of the 5-HT2A receptors. So these receptors get activated. They're G protein coupled receptors. They're diffusely expressed, and a whole bunch of signaling cascades get activated after the serotonin receptor is activated itself. And the downstream, I'm going to go through this extremely quickly, but the downstream effect is ultimately there's an increase in gene expression. And these are genes that tend to be coding for proteins involved in neuroplasticity. So moving on to the next slide. So there's 5% or so of cortical excitatory neurons become transcriptionally activated. These are the so-called trigger population, and they reside in densely connected regions, the prefrontal cortex, namely, and the claustrum, which is deeper in the brain. Well, there may be this modulation of synaptic connections again through the activation of these immediate early genes that get turned on and ultimately translated. And that results in changes in functional connectivity between regions of the brain. What we see also happening is there's a subsequent 5-HT2A receptor internalization that occurs. And that happens in both the activated and non-activated neurons. And that seems to be associated with the reduction of anxiety, in at least in animal studies and rodent studies. And there's also crosstalk with the glutamate system in the brain. So there's enhanced glutaminergic transmission, particularly in the medial prefrontal cortex, increased trafficking of glutamate receptors, this AMPA receptor, and expression of BDNF, that's a brain-derived neurotropic factor. We know that decreased BDNF is associated with major depression and tends to normalize with successful antidepressant therapy. Interestingly, ketamine is believed to exert its robust antidepressant activity via this AMPA activation BDNF expression pathway. So while ketamine works on glutamate receptors and has a different initial mechanism of action than the classic psychedelics do, there are some similar downstream effects, and that may speak to why both seem to cause significant improvements, or at least seem to cause significant improvements in depression for certain people. This is a quote unquote simplified graph of what's happening here, but I show this to demonstrate that there's quite a bit of hard science going into the field of psychedelics, and they're really been working to characterize the cascades that are involved. But ultimately what we see here is activation of the receptor leading to activation of this downstream cascades, leading to gene expression, including increase in BDNF production, glutamate receptor trafficking, and ultimately resulting in increased neuroplasticity, including synaptic plasticity. So I've been talking about this idea of neuroplasticity. This is a graphic that kind of explains what it is. So we can also break neuroplasticity into molecular, neuronal, dendritic, and synaptic categories. But basically at the cell level, there's increased signaling pathways, gene transcription, protein synthesis that actually can result in the production of new neurons in certain parts of the brain. In neurons, there can be increase in dendrite formation. These are called structural plasticity, neurogenesis and dendritogenesis. And then amongst neurons, there can be a strengthening of synaptic connections and the creation of new synaptic connections as well. So it seems like there's immediate effects. There's the experiential component of psychedelic medicines. And then there's this subsequent neuroplastic response that begins in the acute period and then extends again for days to weeks afterwards. So at the regional level, psychedelics reduce the stability of established networks of the brain, the default mode network being one of them. That's the part of the brain or a series of networks in the brain that are involved in self-referential processing, as well as visual, auditory, and sensory motor cortex. This reduction in stability of some of these networks may be what's associated with the ego dissolution that can occur at higher doses of psychedelics, the loss of the sense of self temporarily. And there's an emergence of brief and persistent connections between networks that often generally don't have significant association. So some networks get turned on while other networks get turned off. And the research that has demonstrated these effects has led to the so-called entropic brain hypothesis. This is the idea that in normal waking consciousness in healthy adults, we tend to be somewhere on a spectrum between low entropy states of consciousness and high entropy states. In low entropy states, as we move along the spectrum to a lower and lower entropy, these tend to be more rigid states of mind. So that can be a situation that results in depression rumination, obsessive compulsive disorder, or addiction, more rigid, narrow thinking, feeling of getting stuck, kind of cognitive loops. On the high entropy side, as we start to move forward, we might see more creative thinking, but as we move further and further along the spectrum, we'll see more magical thinking, perhaps even early psychosis. And so there's problems on both ends of the spectrum. We tend to live our lives somewhere in the middle. But how psychedelic medicines, should they prove to be successful clinically, a proposed theory on how they may work is in pulling people who may be stuck more on the right side in the low entropy states, in the depression, OCD side, and moving them more towards a higher entropy state, where they may become more psychologically flexible and ultimately relieve psychic suffering. So when we think about how psychedelic medicines might work in comparison to how SSRIs or classic antidepressants might work, this model has been proposed. SSRIs seem to work via signaling, postsynaptic signaling of the serotonin receptor 5-HT1A. And the way it helps with depression seems to be by reducing limbic responsibility, reducing stress, impulsivity, reducing aggression and anxiety, increasing resilience, but also causing an emotional blunting, but ultimately reducing depression. Whereas with 5-HT2A receptor signaling via psychedelic medicines, again, perhaps by increasing cortical entropy, there's a reduction in rigid thinking, an actual increase in environmental sensitivity and emotional release, and perhaps increasing well-being that way. So it's hard to go a week these days without seeing some kind of headline in the news about a new study involving psychedelics and its promise for various disease states. And much of the interest seemed to come after the publication of Michael Pollan's book, How to Change Your Mind. But just a tremendous amount of research and published papers have come out in the last 10 years or so. And again, they're getting published in larger and larger journals, recently in the New England Journal of Medicine. Much of the interest in the research world came from a couple of published papers back in 2016. These were done by a Johns Hopkins group and an NYU group, and they studied patients living with cancer who are suffering from psychological distress, receiving a single dose of psilocybin versus a placebo. So this is the Johns Hopkins study. It was a 2-session double-blind crossover study comparing a very low dose of psilocybin, which functioned as the placebo, versus a moderately large dose. Most of the patients received the 22 milligram dose. 51 patients initiated the study, all had life-threatening cancer diagnoses, either stage 3 or stage 4, disease progression or recurrence. The DSM-4 diagnoses that people had coming into the study were primarily adjustment disorders, chronic adjustment disorder with anxiety, adjustment disorder with mixed anxiety, depressed mood, as well as dysthymic disorder, generalized anxiety disorder, or major depressive disorder. Following the enrollment, patients met with 2 session monitors at least twice for preparation. During the treatment sessions, monitors were non-directive. They maintained a supportive presence and encouraged the patients to trust, let go, and be open. Following the treatment session, on the next day, there was an integration session, generally lasted about an hour. And then patients met with their monitors at least twice between the first and second session, with a mean of 2.7 occasions. And again, they met at least twice between the second session and the 6-month follow-up. So the treatment session was one part of a larger protocol in which patients received quite a bit of preparation and then quite a bit of integration. This is what a treatment session might look like: a living room environment, 2 session monitors there to ensure safety. During the session, the participants were encouraged to lie down on the couch. They would have eye shades and headphones on. They would listen to a pre-set music playlist. They were encouraged to focus on their inner experience, and then they were monitored for physical and psychological safety as well. Primary outcome measures looked at these particular measures: the grid HAM D17 and HAM A, looking at depression and anxiety responses specifically. They defined clinical responses at 50% or greater reduction, and remission defined as a significant response plus having a score of 7 or less on the scale. They looked at a whole bunch of secondary measures as well, including those that address issues of meaning, acceptance, and fear of death. Assessments were made at baseline, and then five weeks following each session, and 6 months after the second session. They did a number of questionnaires as well, including the mystical experience questionnaire. The persisting effects questionnaire was also assessed, and that included these questions: how personally meaningful was the experience, and indicate the degree with which the experience was spiritually significant to you. So here's the data, and what you see primarily here is that immediately after the psilocybin session, the red group, the people who received it first, there was a significant reduction in measures of anxiety and depression. Interestingly, the group that received the low dose, which served again as the placebo here, did you should see trend towards improvements as well, likely because they were receiving quite a bit of psychological support as part of the protocol for the study. So they started to see some benefits, but then when they got their dose post 2, they effectively caught up, if you will, with the high dose 1 group. Just some graphs comparing the clinically significant response. Again, this is prior to the first blue and red columns here, prior to the crossover. Clinically significant response to depression and anxiety was significantly improved in the high dose versus the low dose, and then it endured in 6-month follow-up. And what they also saw was that response seemed to be correlated with the mystical experience score on the MEQ30, the mystical experience questionnaire. So folks who tended to have a stronger, so to speak, mystical experience tended to have greater clinical responses, as well as the secondary responses of how personally meaningful or how spiritually significant was the experience for you. So just the summary of these results: there were no serious adverse effects. That's not to say there weren't side effects. Generally, the common side effects that you'll see in these studies, which will be quite common, would be headache, nausea, anxiety can occur, elevations in blood pressure and pulse as well. But no serious adverse effects occurred during this study. There was an overall clinical response rate at 6 months, and depression of 78% of participants, anxiety in 83%, and symptom remission at 6 months, 65% for depression and 57% for anxiety. Additionally, over 80% endorsed moderate or higher improvement in a sense of well-being or life satisfaction. And there was that association that we just talked about between the mystical experience questionnaire and enduring therapeutic outcomes. Okay. So similar study was done with the NYU group. They took sorry, this was a blinded 2-session crossover study. So similar patient population. 29 patients completed the first dose, 23 completed the 6-month follow-up. Their study design was slightly different in that they compared a single psilocybin dose to an active control. So not a high versus a very low dose, but a high dose compared to a different medicine. In this case, niacin. They were hoping that the flushing experience of niacin might have people believe that they perhaps received the psilocybin dose. Blinding is always extremely difficult in a study that has potential for a profound experiential or psychological effect. Their primary outcome measures were hospital and anxiety and depression scale, the HADS, Beck depression inventory, and the STAI. And they also looked at the MEQ30 and asked questions regarding personal meaningfulness and spiritual significance. So similar response as we saw in that first study. Patients noting a pretty significant reduction in depression and anxiety scores prior to crossover, comparing the group that received psilocybin first, compared to the group that received the niacin first. This kind of just shows that the effects here: positive behavioral change, personal meaningful experience, spiritually significant experiences, initially much greater between the group that received psilocybin compared to the blue bar, which is the folks who received the niacin first. And then after 4 or 6 months after the second dose, there was a convergence. So after everyone had received the psilocybin, there were similar effects across the board. At the bottom here, we see similar effects in the first session. People who received the psilocybin had the higher MEQ scores. In the second session, the people who then received the psilocybin second had the higher MEQ scores. And looking back on it, they had similar scores. So they noticed that, again, folks who tended to have a mystical experience while receiving psilocybin, that correlated with clinical response. So the authors proposed that there may be 2 things happening here. There may be a direct pathway where the psychedelic medicine is causing somehow a reduction in anxiety and depression, but there also may be an indirect pathway where just having a mystical experience could result in a beneficial, therapeutic outcome. So they propose that 2 things may be happening. We've talked about mystical experience quite a bit now. They have gone ahead and defined it formally here. The features of a mystical experience I put down here on table 17.1 from a paper that we've cited at the end here, but they involved unity, which is a core feature, a strong sense of interconnectedness of all people and things, that sense that all is one. That's sometimes felt as a sense of pure consciousness, sacredness, reverence, awe, or holiness, a noetic quality, which is the sense of encountering an ultimate reality, transcendence of time and space, a deeply felt positive mood, and ineffability. So a sense that an experience cannot be adequately described with words without paradox. So these are the factors that go into ultimately a mystical experience. Okay, so results summary again, also no serious adverse events. And 7 weeks after the first dose, 83% of patients in the psilocybin first group met criteria for depression response versus 14% in the control group. 58% met criteria for anxiety response versus 14% in the control. And at 6.5 month follow-up, when everybody had received the psilocybin, depression anxiety response rates were in the 60 to 80% range. And again, that mystical experience or the MEQ score correlated with improvement in outcome measures, signifying both those direct and indirect effects. And when people were asked to comment on personally or spiritually meaningful, the personal or spiritually meaningful nature of the experience at the 6.5-month follow-up. 52% rated it as the singular, and 70% rated it within the top 5 experiences of their lives. 87% reported increased life satisfaction or well-being. So the NYU folks took a number of the responders in this study and interviewed them, and they put together this video. So remember, these are the responders. They're not talking about people who may have not had a significant response here, but as we're looking at all these numbers and response rates, I thought it would be a little bit more powerful for you to hear from the patients themselves.
When you're anxious about cancer, everything else becomes anxious.
The second that someone tells you that you might die, everything changes.
Always in my life, I've been an anxious person. Naturally, when I was given that diagnosis, my anxiety shot up.
I would just lay on the couch. I didn't go to work.
I was extremely anxious that my cancer is gonna come back.
Anytime they gave me good news, I would kind of ride on the high of my friends. Like, I had no sense of relief of it, that things were going well, even though they were. I couldn't feel it inside.
I used to drink quite a bit to get rid of the anxiety, but it was only temporary.
Anxiety about myself, my purpose, my body, my future, and it also led to a lot of depression.
The more I drank, the more anxious I became that I'm not healthy and I'm gonna get my cancer back.
I'm very attached to living. I like living, I don't know about dying.
Initially, it was absolutely terrifying. I was just terrified.
I was floating on this immense, expansive, infinite sea of strength, of beauty.
I saw my fear.
There was no difference between that infinite sea and me.
All of my fear turned into anger. I will not be eaten alive by this fear. And once that happened, it was just gone. The fear was gone.
I felt this connection with everything.
I wish I could put into words, but a sense of a connectedness that runs through all of us.
It was so peaceful and so beautiful.
I also felt a tremendous connection to everyone I've ever met and known in my life.
It was such an epiphany for me. The cancer and the friends and the family and the past relationships and the present relationships, they're all together, and they're all connected.
I felt that I was bathed in love.
I was feeling pure love.
Just all-encompassing love. And I kept that feeling through the entire experience and the next day, and I still can experience this frequently.
I felt this enormous rush of self-love, and I did not feel separate anymore.
But I just had gratitude that I'm here, and gratitude for everything, for being alive, no matter what happens.
Now I know that, what we call death, I just do not feel that it's at all an end.
So I saw myself from a distance, and I was lying down on a stretcher in front of a hospital. I came to an epiphany, like, oh look, why, you don't let yourself being terrorized by other, thoughts that are nonsense. So why let yourself be terrorized by this thought? That's when I saw some sort of black smoke come out of my body. You're done with this. You finished your treatment. You've gotten out of the hospital. On your way out, you've also gotten rid of your anxiety. So now you're out. That's it. From now on, your life is great.
The message coming to me is that you don't know how it's going to end. You don't know what your death is going to be. And that's just part of the deal of life. I remember asking if there would be a cure for cancer. And I was told it didn't matter, I was going to die anyway. It's just the nature of things.
To feel separate and to feel alone is just a falsity, because it's not how it is. And that's very comforting. And I've felt that way ever since.
I find myself so much more connected to everyone and everything. What greater blessing is that? Especially for a person who held herself apart.
I always felt like the kid who had their face pressed up against the window that wasn't invited to the party. Now I can look and I can take a measure of joy in saying, wow, these people are really enjoying themselves, and I don't feel like I've missed out.
And since the experience, I have enjoyed so much more of my life.
Understanding that death will happen and being fully aware of its reality, which I think a lot of people aren't, enables you to have a happier life. And that's an irony. People would just be so much happier if they would just admit that they were going to die.
I finally came to realize that I have been a very dissatisfied person. Just never satisfied with anything. And so if I found something I liked, then, well, there was always something not quite right with it and I needed something else. This kind of made that go away. I really have what I need. A lot of people don't. Most people in the world probably don't have what they need. They don't even have the basics to survive. And I have everything I need. And I'm really happy about it.
I was on the treadmill the other day, and this thought entered my mind, just came through my mind, and it said, I want for nothing. Nothing. That's how it's been. You know, my life is exactly the same as it was before. Could give you the same list of complaints that I had before that, including getting that cancer diagnosis, you know, including everything that I can think of that I don't like about my life, and yet it doesn't matter anymore.
There wasn't a part of my life that it didn't make better.
I have a greater awareness.
I was able to let little things go much easier.
A better capacity to listen.
I could sleep without medication.
To not feel compelled to talk out of neurosis.
It reminded me who I am, but it also made me a better version of myself.
Right now, it's not even that I'm not anxious about cancer. I'm just not anxious about dying. I'm fine with it.
Somebody called me up today and they said, how are you? And I said, wonderful. And I am 65 years old and I have never, I just heard that coming out of my mouth. I have never said that. Never.
I never felt that I really deserved to be alive. I never felt that I really belonged. I feel like that's gone. That, yeah, I do deserve to be alive as much as anyone else. I belong.
I'm one of the luckiest unlucky people. You know, I was unlucky, got cancer, but I was lucky that I was chosen to be in this study. And it did change my life.
Here's some comments from Annie. This is from a prior pilot study that was done at Harbor UCLA. So the pilot study, which I didn't talk about today, that kind of led the way for both those Johns Hopkins study as well as the NYU study. So Annie was a 53-year-old woman with a diagnosis of metastatic ovarian cancer. And 6 months after her participation in the Harbor UCLA cancer anxiety study, that pilot study she wrote, I had lost faith because of my anxiety and I was just terrified. I was so anxious that it was hard to think about anything else. I didn't think I was so worried about death as I was about the process of dying, about suffering and being in pain and having all kinds of medical procedures. I was becoming so irritable with my husband. I was just so anxious. My intention for participation in the study was to be able to control my anxiety so I could enjoy the rest of my life. I was not enjoying my life at all. As soon as the psilocybin started working, I knew I had nothing to be afraid of. It connected me with the universe. It was very gentle, and there were people, the treatment team, right there if I got upset. Everything looked absolutely beautiful. I didn't see things that weren't there. With my eyes closed, I saw patterns and visions and faces. I thought about being involved with people I loved, things I would do with people I knew, things I would tell them. I had an amazing spiritual experience. It reconnected me to the universe. Comments from her husband 4 months after her death. Annie's mood remained greatly improved for some time after the treatment. She also had much less anxiety, and her fear of getting sicker and her fear of the dying process also diminished a great deal. Beyond that, she and I got along much better after her psilocybin treatment. I have no doubt that the treatment Annie went through was of great value to her. So as we heard, this account, as well as the patient's testimonials in the video, you could kind of hear some of those themes of that mystical experience questionnaire and the definition of the mystical experience come up quite a bit. Okay, so after these papers were published, a lot of the research kind of moved on from a palliative patient population or a population of people living with cancer and kind of moved to more classic psychiatric diagnoses. Okay, so I'm going to skip through these. These are some follow-up studies that were done primarily on depression, both major depression and treatment-resistant depression. So there have been quite a few studies done, both again, treatment-resistant depression, type 2 bipolar depression, alcohol use disorder, tobacco use disorder, opioid use disorder, cocaine use disorder, cluster headache, post-traumatic headache, demoralization. The list actually goes on. So quite a robust research efforts going on. We're starting to see the publications of those now. Some of them have similarly impressive results. Some are a little bit more muted. As we go into the future, we'll see kind of as larger scale studies go online, what the results are going to be. Again, looking more at the classic psychiatric diagnoses that tend to be studied. If you look at a more recent view of the NYU and John Hopkins websites, you'll see they're very heavily engaged in research now as well. So what's happening at the federal level, psychedelics and the FDA? We're not really talking about MDMA today, but I included that here. In August 2017, MDMA was designated as a breakthrough therapy by the FDA for severe PTSD, and that's presently in phase 3 trials, one of which was recently published. In October 2018, psilocybin was designated a breakthrough therapy by the FDA for treatment of resistant depression in phase 2 trials that are sponsored by a company called Compass Pathways. And then in November 2019, psilocybin was designated as a breakthrough therapy by the FDA for major depressive disorder, also in phase 2 trials sponsored by the USONA Institute. And ketamine has been available as a Schedule III drug since 1999. And is often used off-label as a novel psychedelic for folks with various psychological challenges. There is an FDA-approved version of ketamine that's used for treatment-resistant depression under the brand name of Spravato, and that's a nasal spray. It's actually the S-ketamine that's used there. Just looking beyond the CNS briefly, in low doses, there does seem to be an anti-inflammatory component in the periphery that seems to occur with psychedelic substances. This tends to be in animal studies, but that's actually an area of research interest as well. These would be using doses that are far lower than what's used in psychedelic therapy, so these would be subperceptual. But there's some interest in using very low doses of psychedelic type medicines for biomedical problems like asthma, cardiovascular disease, IBD, or rheumatologic disorders, diseases that have an inflammatory component. And of course, for psychological issues such as depression, demoralization, substance use disorder, PTSD, OCD, spiritual exploration, as well as professional burnout. So there's both sort of classic DSM-4, DSM-5 diagnoses, as well as other problems or challenges that might face folks in every aspect of life. So current legal access points in the United States, it's quite limited. Enrollment into an approved clinical trial is the primary mode. There are a few churches that are recognized by the federal government who utilize psychedelic medicines as a sacrament. The Native American Church, União do Vegetal and Santo Daime. And the right to try pathway isn't currently available, but there are lawsuits going on and efforts to utilize the existing right to try pathway, which is primarily utilized as an effort for people with advanced illness, for example, cancer, who's progressed through the standard lines of chemotherapy to gain access to investigational therapeutics. So there have been efforts in a similar population to use psilocybin under the same legal pathway. And that's actually currently being litigated in the courts. Sort of going back to palliative care, what access points might be available for a palliative care population interested in pursuing psilocybin therapies? Of course, pending the larger clinical trials occurring and FDA approval and ultimately DEA rescheduling. Well, options include travel to jurisdictions or countries where psilocybin is a legal therapy, engaging in a research trial, again, that right to try pathway, which is currently under investigation, litigation. State-led initiatives have been occurring, most famously in Oregon and now most recently Colorado. Of course, the FDA approval and rescheduling, so that will require some years before that could become a reality. And of course, there's off-label use currently of the FDA-approved medication ketamine. It's not FDA approved as a psychedelic medicine, it's FDA approved in the context of anesthesia. And again, in a specific context of treatment-resistant depression with S-ketamine. Looking at some research efforts here though. Oh, I'm losing my my earbuds. Can you still hear me okay? Yes, okay. Just looking at the research going on here for a palliative care population. Dana-Farber has put together a study specifically for patients enrolled on hospice to receive a dose of psilocybin, and they've dosed their first patient within the last few months. So that's example on the right. And there's a cancer center in Maryland, the Aquilino Cancer Center, that's invested quite a few resources in building a psilocybin treatment research program that they hope will benefit their patients. I have yet another video here to show you. This is from the Aquilino Cancer Center itself, and their little promotional video that they've put out.
When a patient has a cancer diagnosis, it's overwhelming. You're trying to figure out, what's my diagnosis, what's the pathology, chemotherapy, radiation, trying to make the appointments. And even though there's a sense of the emotional toil the cancer is causing, it almost gets neglected. And so we're saying that we take your suffering seriously, so much so that we're going to build a dedicated space that's beautiful, that's costing healing, and this is just to meet that need. And this will be one of the first spaces in the country to do that.
We are dedicating this 2,700 square foot area to a purpose-built space with new kinds of therapy in pursuit of what it means to have that healing experience of mind, body, and spirit.
One of my personal favorite focuses of research is in palliative care and the work with cancer patients. We have lots of work to do, but the promise of this field is really incredible.
"15 years ago, my late wife died of cancer. Little did I know when we built this center that we would be on the cutting edge of helping people with depression and anxiety that were diagnosed with cancer.
This is a way to turn the chapter in cancer care and make comprehensive cancer care about not just the physical body, but the entire body, and deal with the deep psychological and burdens that cancer patients face. And we can shape a new future for cancer patients.
This is an example of the travel option. This is a presentation that was put together in last year's AHPM annual assembly, where the authors here helped put together a retreat in Jamaica for bereaved parents of children who had passed away. And so they described their process and putting together this retreat. I think the retreat, the program they put together is still in existence. You can find it on Google, but they describe the development and implementation of their retreat in Jamaica. So it wasn't for patients living with cancer themselves, but it was a kind of a group therapy type or a group. They were careful not to call it therapy, but a group support kind of experience for the parents. This is a little bit more on the right to try pathway. So in 2018, there was a federal law that was passed that opened up the right to try pathway, and it was a way for, again, people to gain access to investigational therapeutics that bypassed the current FDA route of expanded access. In this year's Congress, because there were those issues that I alluded to, there's been a bill proposed that would clarify the Right to Try Act specifically to allow for use of Schedule I medicines that are currently under investigation if the other criteria are met. I think they would respect state law, so certain states specifically in their right to try laws might have exclusions for Schedule I drugs. I think this would respect those exclusions, but it would allow for use in states and jurisdictions that don't have that exclusion. I know the year is coming to a close, and there's going to be a new Congress coming on. So I'm not a legal expert. I'm not certain what the status of this bill is. I've been trying to follow it where I can, but it doesn't seem to have been passed quite yet. This is what's happening in Oregon and their state-led initiative. Interestingly, it's not a medical model. People don't need a medical referral when these treatment centers go online. And they're not using pharmaceutical grade psilocybin. They're using plant medicine. So this is what's happening in Oregon. It hasn't gone online yet. They've been in this planning phase up until now, and they're moving on to the implementation phase, I believe, in early 2023. Again, in this year's midterm election, Colorado passed a similar bill that will ultimately function in a way quite similar to the Oregon model. So we'll see as these two states implement their programs. Hawaii has proposed similar legislation in the past, in 2020 and 2021, and I think 2022 as well, but it hadn't passed the legislature. So when we think about psychedelic therapies and where they're at right now, there are some unanswered questions still. I mean, the research is ongoing, but as we move forward, some questions that I've had, things to consider. What's the best model? In medicine, we tend to assume the best model would be a medical model. These are medicines that have perhaps effects on things like depression and anxiety. But they've been used for thousands of years outside of a medical model per se. So, we could think about a model that would be more spiritual or social community. That's sort of similar to what's going on in Oregon. How would indigenous people be properly compensated and recognized? Many of these substances were used again for thousands of years by indigenous peoples, and we're sort of now at risk of doing our medical colonialism that we've done, unfortunately, all too well over the course of so many years, and extracting these substances, purifying them, modifying them, and commercializing them, and we need to make sure for these medicines that we don't make the same mistakes. What's the appropriate business model? How do we ensure equity? In the ketamine space, a lot of times there's worry that, these are medicines that are cash pay, they tend to create medi spas and things like that. How do we ensure that it's not just the wealthy and moneyed class that can access these medicines, if they do indeed become FDA approved and are shown to be useful? How do we make sure that everyone gets access who would otherwise benefit? How do we ensure best practices are established and the highest ethical standards ensured? Would governing bodies be established, and if so, under whom? There has been the creation of a psychedelics board, so people are working on this. But ethics is extremely important. People under the influence of psychedelic medicines are inherently in a vulnerable state, are at risk of being taken advantage of. And we have to ensure that practitioners adhere to impeccable ethical standards. Safety is paramount. And we still don't know exactly who would most benefit and which people might be best avoiding psychedelic medicines. The research is pointing to factors, but it's incomplete. We need a little bit more information. So in summary, psychedelics are medicines with an experiential component. There seem to be direct anxiolytic and antidepressant effects. They work by increasing neuroplasticity and increasing brain entropy. Their experiences themselves involved that may be personally and spiritually meaningful. Psychotherapy is combined to enhance the therapeutic potential and prevent harm that could result from challenging or destabilizing experiences. And the therapist helps to work through material that may have been previously repressed. It requires a transformative therapeutic model. It's inherently interdisciplinary. It carries cultural, spiritual, historical, and clinical relevance. And again, potential practitioners must hold the highest ethical standards to ensure physical and psychological safety. So I know this was a bit of a whirlwind tour, and we're skimming the surface of a lot of these issues, but I was doing my best to kind of keep us as close as we could to an hour. But thank you everyone for your time. I hope this was useful. I hope it was interesting, perhaps inspiring, and I'd be happy to answer any questions that have come up along the way.
Well, thank you very much, Ilan. That was great. Boy, you got a lot of information into an hour. So for those of you who want to review what he's shared with us, we'll be recording and then posting this up on the web. So you can go back and re-listen to this. So Ilan, there's been a couple of questions that I'll start with, and people can put other things into the chat. So the first one is, have there been any studies on psychedelics for pain control, specifically MDMA?
In the 1960s phase of medicine, or psychedelic medicine studies, they were looking at analgesia in the context of cancer pain. There may be, I'm afraid I haven't come across that. It has been an interesting research idea, though. If we think about total pain and palliative care, a lot of that is linked to psychological distress. For folks who have a lot of pain that may be also informed by that, the total pain, it follows that a therapeutic response might serve some kind of analgesic benefit and serve to perhaps, for example, reduce opioid requirements and things like that down the road. So I haven't encountered that data in the at least in the 21st century research. It may be under investigation right now, but I'm not aware of it.
Okay, thank you. So Fariel asks, can you touch on microdosing that some patients are doing on their own and international retreats for psilocybin use?
Yeah, so microdosing is I mean, it's a different paradigm, and there are quite a few people that do engage in that, and there's protocols out there that have been developed for it. I think the research right now, a lot of it is observational and it's survey based. I haven't seen like the randomized controlled trials on it. But people, so there's quite a bit of reported use and people saying that they derive potential benefit from that. I think it is also an interesting point of study. Some of the promise, if you will, of the psychedelic medicines in cancer was that these were, robust responses that occurred with a single dose in a medicine session. The idea of a microdose, of course, is that these are doses that are much, much smaller, but are taken much more frequently. Not every day, but regularly. And so we kind of walk away from that sort of idea of, a singular event resulting in a prolonged beneficial response. On the other hand, one could imagine if a full-blown psychedelic experience, might be frightening or too much, perhaps a microdose would be more appealing. So we just don't know. I don't think we have the comparisons out there yet. I think it's worthy of research as well, and we'll see. As far as international retreats, they're out there, and I think it's just important. When we're talking about leaving the United States to go on a psilocybin retreat, I mean, we're putting ourselves out there, and my understanding is there seems to be retreat centers that are of high regard and perhaps some that are less so. So it requires a little bit more investigation. It requires some caution. They may not all be built equally and have the same safety standards. So that's the challenge here when we're thinking about the travel. The travel pathway, if you will, is that if we're talking about a population who's living with a serious illness, it's not easy to travel. And B, we have to do a little bit more due diligence to ensure that those ethical standards are being met. And they may be, but oftentimes there's more word of mouth and things like that involved.
That makes sense, certainly. Wendy was wondering, are there other groups besides Clarity Project that are working on changing psychedelic drug laws in Hawaii?
I believe that's the primary, certainly working with the legislature on that for folks who are interested in that, those kind of state-led initiatives that are similar to what's happened in Oregon and Colorado. There are other practitioners who have gone through training, who are, sort of working on building the foundation of what things might look like should these pathways become legal. So I don't know about other organized groups, but I would say that there is a community of practitioners who are preparing to provide treatments again if and when the therapies do go online and become legal in Hawaii or across the country.
Okay, good. Is hypertension a contraindication to use of psilocybin?
Well, I think hypertensive urgency would be. I mean, they're checking it, but a controlled hypertension, I don't think would be. There are in these studies, there are elevations in blood pressure. I think if people are going into it with worrisome blood pressures, it would give cause. So hypertension in of itself, I don't think is an exclusion criteria. Certainly, dangerously uncontrolled hypertension would be in the studies. Yeah. the blood pressure would tend to go up and then peaks, an hour or two in, and then would kind of go back to baseline. So in the studies that I have seen, I haven't seen dangerous elevations in blood pressure reported, but they do note, systolic BPs going up by 20 milligrams of mercury or so, for example.
Okay, thank you. One other question from Wendy. Any studies on psychedelics and PTSD besides the MDMA study?
They're working on that, yeah. I don't have data, but there has been, there are people looking at PTSD beyond MDMA. If you go on to clinicaltrials.gov and type in psilocybin or psychedelics, what you'll find is there is a lot of research going on. Most of that are smaller trials, but many research proposals out there on quite a few topics and quite a few disease states.
So if people are interested in staying on top of what's happening, what do you suggest?
If you're interested in staying on top of what's happening in the research world, I think that's a good place to go, because you can follow particular studies as you go along. I think the URL is that, is it not, clinicaltrials.gov?
And are there any journals that you like reading or things you would recommend, for the whole field?
They are, I believe the Journal of Psychedelic Medicine or something to that effect is being launched. But what's happening is in the larger studies, they're being published in our classic journals. There was a recent publication, again, in the New England Journal of Medicine last week, looking at treatment-resistant depression. There were positive results there. There were somewhat mixed results, but we're getting these papers being published, not just in niche journals anymore. Those original studies were both published in the Journal, I think, of Clinical Psychopharmacology. And now we're seeing JAMA publishing papers, New England. So you don't have to go to a particular place. They're being published quite broadly.
Good. So you've done a great job of you continue to be succinct and full of good information, but there's a couple more questions here. Brian asks, can you speak to your personal professional experience and interest in psychedelic-assisted therapy in general and specifically as a palliative tool? Brian is asking you, can you speak to your personal and professional experience and interest in psychedelic-assisted therapy in general and specifically as a palliative tool?
Well, I became interested in it, back in 2017 or 2018, particularly in the context of palliative medicine. It was frankly driven primarily by these studies that I talked about today. When we think about the themes of these papers, or the themes of what comes out of these papers and those patient testimonials, for example, they speak to the core of a lot of the issues that we deal with in palliative care. They speak to fundamental issues of meaning making, of facing and confronting life and death, and what is this all about, and I'm afraid of it, and I'm going through. It kind of cut through as I was reading these papers and reading these testimonials, and as sort of somebody who was becoming interested in the space, is cutting through a lot of the stuff and getting at the core of what really seems to be, the issues at hand. And I think that's what drove my interest as somebody who wanted to learn more about it back then. I again, speaking to my personal exploration of the field, I then took a training course at the California Institute of Integral Studies. CIIS has a certificate program in psychedelic therapies and research, and I was a member of the 2019 cohort, which was again, it was an academic program, which provided quite a bit of exposure. So for folks who are interested in perhaps becoming a practitioner or participating in research in the future, certainly that's something to explore. Since then, there's been other training programs that have been developed, and there's at least 2 major ones now. That was my motivation to learn more about the space. You know, of course, we can't provide these therapies currently in Hawaii. So, you know, we're sort of waiting to see how things evolve here. So, you know, in Hawaii, we'll see. You know, it's sometimes things happen on the mainland first, you know, and get to us a little bit later. But like I said, there's preparation ongoing for if and when these become viable therapies for our patients.
Right. So Faryal she was asking, are there courses and conferences that are, you know, that you might recommend? So you mentioned the one in California. Are there any other that you?
Yeah, the other major one, and I don't have my Google here with me, but I think it's the IPI, the Integrative Psychology Institute, has a training program as well. If you Google that, these are like generally 1-year-long training programs.
Mm-hmm. Are there conferences as well?
Tons of conferences. There are many conferences. Yes.
Are there any to stay away from? She wants to know. Kind of, she's asking that.
I don't know that I haven't encountered one that I saw that I was like, oh my God, don't go. There's a major conference in 2023, which is Psychedelic Sciences, that's put on by MAPS. It's going to be in Colorado, in Denver, in the summer of next year. And so that's going to be a big conference. And of course, with Colorado's recent legislation, that'll be, you know, I'm sure they'll be talking about their initiatives there then as well. But yeah, if it's not difficult to find conferences. Lots of centers are putting together institutes. You know, again, Johns Hopkins has an institute. I think NYU does too. Quite a few universities are putting together institutes, research institutes, you know, and put on conferences. So
right,
there are no shortage of conferences.
Well, it's pretty amazing the change and how quickly that happens.
Yes.
Okay, so I noticed the time, but there was one last question, which I think is quite interesting. Wendy asks, do you feel that in order to administer and monitor sessions, you should have experience with taking the substance yourself?
Well, that's a topic that's of great discussion in the field of psychedelic medicine. I would preface it to say that it's important to gain legal access as practitioners. So if somebody were to do that, you know, it would be important to do it above board. What was happening in the MDMA space is they had created effectively a safety research protocol. So they had created a research protocol that for healthy volunteers, effectively to study the physiologic responses to MDMA. And what they did is they enrolled their future therapists into that trial. So that was, for example, a way for these practitioners to gain legal access to the therapy under a controlled and safe setting, and actually experience kind of what they were going to be providing as future providers in the research protocols themselves. So that's an interesting model, to pursue. And then, of course, if there's other legal avenues. So I would say that most people who are deeply
in the space and have worked in the space would say that familiarity with non-ordinary states of consciousness is helpful and perhaps quite important as a practitioner. But I think it's also important that we consider how we gain those.
Great. Well, there's a good place to end. So, Dr. Bernstein, thank you again. This was super interesting. Really, this was a great presentation, and we really thank you for coming and sharing with us today. So, if we were in public, if we were in person, we'd all be clapping now. But thank you very much. That was great. And as I said, we'll be there's thank yous in the chat and all sorts of clapping emojis appearing. So thank you, Ilan.
Well, thank you. Thanks everyone for your time and attention. I really appreciate it.